Good morning and welcome to the Focus Symposia in Men's Health, a global problem and new frontier for physiotherapy. Just before we begin, could I please get you to stand for a moment? Today we're going to learn about some yoga poses to indicate strength and masculinity. Starting off, I'd just like you to raise your arms above your head, have your feet together, link your hands and just try and make yourself extremely tall, as if in the pose of a mountain, reflective of Table Mountain that we have here. Gently breathing in and out, feeling your spine tall, and then just bring your hands down into our peace pose. Welcome, everyone. Education is the most powerful weapon which you can use to change the world. In my opinion, were the most important words spoken by Nelson Mandela, whose real name, Rolisha Shah Delabonga, literally means troublemaker, or the tugging of the branches of a tree. And after starting life herding cattle and sheep, Mandela went on to educate us all. It is therefore a very proud moment to be standing here in Cape Town in the very footprints of Mandela, to be part of the first ever Physiotherapy Focus Symposium in Men's Health. In recent years, all around the world, men's health has established itself with a unique identity all of its own. In physiotherapy, there is a focus on urinary incontinence issues and bowel incontinence, sexual dysfunction, and chronic pelvic pain. However, it is just the beginning, and there are challenges. Here to help confront those challenges are members of my Men's Health Focus Symposia team. May I firstly introduce my co-chair, Professor Paul Hodges, from the University of Queensland, Australia. Next, we have Dr. Ruth Jones from Southampton University, representing the United Kingdom, and Jared Green from the University of Birmingham, United Kingdom. And finally, Somto Nwanko from Nigeria was meant to be here. However, unfortunately, at the very last moment, his visa was rejected, and instead, we have Khalid Nazir from Egypt and the US representing us from Cairo University. Please make them all welcome. But first, for a little history. In the beginning, there was Adam, Eve, and God. Fast track to 2015's WCPT conference in Singapore, there was a meeting of fate between Jared Green, myself, and the goddess of women's health physiotherapy, Professor Carrie Bow. Unfortunately, in Singapore, there was no home for men's health. Instead, there were two presentations by myself and Paul, and we were placed in professional practice. However, since then, international organisations have worked to try and have a think about name changes, and indeed, the men's health focus was initially granted by the New Zealand Physiotherapy Association with a name change to Pelvic Women and Men's Health Group. This was soon followed by the Australian Physiotherapy Association under the leadership of Heather Pearce and Alexandra Lopez. And today we have men's, women's and pelvic health included as one title. So what about today? As Pauline Schiarelli stated in 2011, men's health is 30 years behind women's health. And this, in the context of physiotherapy, which represents 50% of the global population, is something we need to consider. And indeed, the average man on the street all around the world lives 5 years less than his female counterpart. If we look at South Africa, this gap is even bigger, with a 7-year age gap, 59-year average for men and 66 for women. In Australia, the gap is 5 years, 80 for women and 85 for men. Sorry, I've said the wrong thing. 80 for men and 85 for women. The World Health Global Organisation states that men live an average of 68 years around the world and 73 years for women. If we look at the top 10 global causes of male death in the world, we see that most of the top 10 are possibly preventable with a little education. Looking at ischemic disease and stroke, or road injury and tuberculosis towards the other end, public health campaigns can actually contribute to most of these problems decreasing, as seen in more advanced nations. Unfortunately, men also lead in adverse health statistics globally. Today, 1 in 2 men are diagnosed with cancer versus 1 in 3 women. 1 in 7 men will get prostate cancer versus 1 in 4 African men. 1 in 4 men over 18 years of age is at risk of a cardiac event due to obesity. And 1 in 8 men will develop a mental health condition. We also know that 40% of men at 40 years of age and 50% of men at 50 years of age have both possibility of erectile dysfunction and benign prostate hyperplasia or enlargement. Sadly, 80% of all suicides are committed by men. Globally, 1 man dies every minute. Why is this so? It has a lot to do with male attitudes towards health, and boys learn from a very early age that the primary goal is about performing, action, and getting the job done, with asking for help often a foreign concept. Socialisation is often side by side, with common male traits of aggression, independence, stoicness, and dominance all being part of normal behaviour. When it comes to identity, sex and manhood is linked to the penis and erections, and any dysfunction is a loss of masculinity, and very few men wish to talk about that with their mates. Recognising that perhaps being a female, I needed to have the male point of view in my own work, I decided to contact 3 men's health physiotherapists around Australia. Craig Allingham, Peter Dornan and Stuart Baptist were very happy to collaborate with me, and we spend quite a lot of time now teaching other physiotherapists in Australia all about the men's health point of view. Ironically, the boys actually asked me to be the ones to talk about sexual dysfunction. May I, on this note, please introduce Australia's leading men's health pelvic physiotherapist, Professor Paul Hodges.
Well, thanks, Joe, for starting the session with those sobering statistics. What I'm going to talk about today is work that we've been doing trying to understand continence and incontinence in men, and so I'm trying to change the perspective of how we look at this function and dysfunction in men, because it is different to what it is in women. And so what we know is that men experience incontinence surprisingly frequently. Up to 39% of men have symptoms of incontinence of some type, and that's increases with advancing age. Post-prostatectomy incontinence is the most common. Up to 60% of men experience incontinence after prostatectomy, and symptoms extend beyond 12 months for many. It has a major impact on the quality of life for these men. It made a lot of sense in the early days because of the high level of evidence for efficacy of pelvic floor muscle rehabilitation in women that these techniques should be applied to men to consider modifying the outcome for incontinence. Early RCTs, including the one by Marieke van Kampen, had a very positive clinical outcome. But more recently, there's been large RCTs and Cochrane reviews that suggest that there's really very limited evidence of efficacy. And one of the things that we need to consider is it appropriate to apply the techniques that we use for rehabilitation of pelvic floor function in women directly to men? And one of the things that we've been considering in our research is maybe one of the reasons that the interventions haven't been as successful as they perhaps could be is maybe we're focusing on the wrong muscles. In women, it makes a whole lot of sense to focus on levator ani because these are the muscles that are primarily impacted by vaginal delivery. But in men, the primary reason for incontinence in many men is prostatectomy, a completely different mechanism which doesn't impact on the levator ani, impacts on other muscles. Maybe we have different treatment goals. In women, there's class 1 evidence for repeated maximal contractions of pelvic floor muscles for improving continence function. But in men, maybe we have a different physiology that needs to be modified in order to restore continence after prostatectomy. And maybe it's the wrong time. Most of the large clinical trials with limited success manage incontinence after it's developed rather than trying to prevent it. So what I want to do in my next 10 minutes is to give you a brief idea about how anatomy may differ between men and women in terms of muscle. Other features that differ are obvious. We want to consider some of the new recording techniques that we've been working on, the function of male pelvic floor muscles for a range of different functional activities, pathophysiology, particularly with respect to post-prostatectomy incontinence, because that's the thing that we've investigated most extensively, and then some ideas at the end about how we might apply this information into clinical practice. So the first thing is to review what is it that might be relevant in terms of the differences in male and female anatomy. So if we first of all look at the superficial layer, there are a range of muscles. The primary muscles that are considered to have some impact on continence function might be the ischiocavernosus and the bulbocavernosus, which you can see here clearly in women. In a male pelvic floor, the muscles still exist. They have slightly different anatomy, obviously, and bulbospongiosis or bulbocavernosus has primarily been considered to be a muscle associated with ejaculation. If we go deeper, looking at the levator ani, you can very clearly see from this beautiful picture from Delancey the puba rectalis hooking around the back of the rectum, so putting that corner in the rectum for fecal continence, but also providing some compression of the urethra against the pubic symphysis. There's also, of course, the multiple layers of smooth and striated muscle around the urethra, including the longitudinal and circular smooth muscles, and then the horseshoe-shaped striated or skeletal muscle that goes around the front and sides of the urethra, which are able to be controlled automatically through the autonomic nervous system as well as voluntarily through activation. So in men, all of the same muscles exist. There is the smooth muscle of the urethra that runs through the prostate and associated with the bladder neck. There is the levator ani muscles, the striated urethral sphincter, and the bulbocavernosus. There's various names given to each of those muscles in the literature, and I've listed them there because it can get very confusing when you read different papers because you don't know whether they're talking about the same thing or not. But what you can see is that there are multiple different mechanisms, some mechanisms pulling forward, some pulling backwards, and maybe those muscles working together might provide an effective mechanism of continence control. So how do we measure these muscles? And that's been one of the barriers to improved understanding of continence function in men. And what we've been doing is trying to develop and validate different measures, some for the laboratory, some for clinical practice. In the laboratory, we use invasive techniques that include fine wire recordings of muscles like bulbocavernosus and puba rectalis, and then transurethral electrodes that suction onto the urethra to record from the striated urethral sphincter. But obviously, we can only use those techniques in a select population of willing participants. The most ideal method is to use non-invasive methods, and ultrasound imaging is one of the obvious possibilities. And as ultrasound devices become cheaper and more accessible, this will become more easily available for clinical practice. Transabdominal approaches have been the ones that have been described most consistently. They do provide information, particularly of levator ani contraction, so elevation of the bladder base through puba rectalis, puba coccygeus contraction. There are some problems in that there's no bony landmark for reference of motion. They can be affected by abdominal displacement, so if you bulge the abdomen, it can make the image more difficult to interpret. And they only provide information about one mechanism, and that is the puba rectalis, levator ani. The other technique is, and this shows an ultrasound image made transabdominally. The next thing we've been investigating is the potential application of transperineal ultrasound imaging in men. And the advantage of this is that because these muscles produce movements in different directions, in different locations on the urethra, we have the capacity to individually investigate each of the components. So you can see that puba rectalis should be able to draw the anorectal junction forwards, elevate the bladder base, and then the striated urethral sphincter should be able to pull posteriorly on the mid-urethra, and bulbocavernosus giving compression of the bulb of penis. And what we've been doing is trying to evaluate and then validate that as measures of activation of each of these different muscles. And I'll show you a video, or two videos, of two different men performing the contraction. The fellow on the left, you can see very clearly that he has a bias towards contracting striated urethral sphincter in addition to bulbocavernosus and puba rectalis. So pulling forward the anorectal junction, pulling backwards on the mid-urethra, compressing the bulb. This fellow on the right, his bias is much more towards puba rectalis. And that's one of the interesting observations we've made, and that is that different men use different strategies, and that may have implication for rehabilitation. So what we've done is to devise a whole series of measures to investigate each of those different muscles, to look at the relative contribution to continence and other functions, and we've shown in our research that there are men who have a bias towards the sphincter and others who have a bias towards levator ani. We've also shown that there's a relationship, although not linear, between the amount of muscle activation recorded with EMG and the ultrasound measures. In terms of function, we've looked at many different things. We need to remember that the pelvic floor muscles perform many functions. They support the abdominal contents, they provide anal and urethral compression, they control intra-abdominal pressure generation, and they perform sexual functions. And there's an important concept, and that is that the pressures from above oppose many of the actions of the pelvic floor. So what your diaphragm and abdominal muscles do has an impact on pelvic floor function. In terms of continence, the literature is very sparse and has argued that most of the continence mechanism is from the smooth muscle components, and then the striated urethral sphincter. There's two schools of thought. One is that it only contracts tonically, the other is that it only contracts phasically. What our data shows is that the striated urethral sphincter contributes both gentle tonic activation plus phasic recruitment when you cough, when you jump, when you do any exertion. Levator ani has never been recorded consistently in men in relation to continence function, but we show a similar thing, some tonic activation with phasic recruitment. And the same thing with bulbocavernosus. Even though it's a long way down the urethra, it still contributes to continence mechanisms. So we've done studies like looking at coughing, where you can see some gentle tonic activation of these muscles at rest and then a burst of recruitment when the person coughs. When we look at an ultrasound image, you can see this contraction of the sphincter and the bulbocavernosus compressing the urethra, and there's a little bit of downward motion of the bladder base as the intra-abdominal pressure increases during the cough. We've also looked at postural functions, because when you control the spine, you need intra-abdominal pressure. You need a pelvic floor muscle contraction both to enable the pressure to increase, but also to control continence. Here's a person performing an arm movement which challenges the stability of the trunk, and the pelvic floor muscles are activating in advance of that. Each of them is activating in advance. When you take a step, you activate in advance of taking a step. This is a sphincter recording during a stepping task. So what goes wrong when there's dysfunction? So if someone has a prostatectomy, you lose what's in this box. You lose the prostate and the smooth muscle that is lining the urethral wall. You may or may not have damage to the striated urethral sphincter. So therefore, if we're thinking about rehabilitation for pelvic floor muscle dysfunction in men, we need to think about compensating for the loss of smooth muscle, plus or minus compensating for damage that might have occurred to the striated urethral sphincter. And the other thing is that many men generate excessive pressure from above, so pushing too hard, increasing intra-abdominal pressure. So there's different patterns, and maybe we need to have tailored, targeted interventions. This is some recent data that we've just published looking at post-prostatectomy incontinence, and men who are continent after prostatectomy have better function of their striated urethral sphincter than mere mortals. So men have to get better function than normal, and men who are incontinent, many of them have poor function of the sphincter. If we look at the levator ani contraction, so the urethrovesical junction, many men in fact push the bladder down rather than support it when they do voluntary contractions, as has been observed in women. So different presentations for different men. So in terms of thinking about then treatment, we need to compensate for loss of smooth muscle, and I think that means that we need to train muscles to work tonically at a low level, which is all you can sustain consistently for a long period without causing ischemic problems in muscles. So gentle tonic activation needs to be encouraged. But on top of that, we also need these phasic bursts of recruitment for function, and we need to think about which muscles are available to do that. Is it puborectalis or is it the striated urethral sphincter? But also making sure that men aren't excessively contracting from above, tailoring the intervention to make sure that we optimise the pattern. So we're going to need assessments that allow us to understand what is the anatomy, what is the voluntary activation, looking at repeated contractions, looking at coughing, looking at whether you can change function with pre-activation before coughing and which muscles might modify the outcome, and sustained contractions. Obviously, ultrasound may provide us with some fantastic objectives to be able to analyse that in great detail, but without ultrasound we can still evaluate those aspects to some degree. In terms of training, we need to look at multifaceted interventions that are going to optimise the pattern of activation, improve strength and endurance, bladder training. We're going to need to think about integrating it into function, and then also high performance training. So it's going to require some intensive education and pattern change. So in summary, pelvic floor muscles in men and women are all the same muscles are there, but there are some slight differences, and that is relevant because I think that has an impact on the way we go about rehabilitating. The function involves complex interaction between these multiple mechanisms, and there's many questions that we still need answers for, but we need to creatively move forwards to try and find the best solutions and then test them. So I'll finish there by thanking the people who gave me the cash to do the studies and the people I've worked with for the experiments, particularly Ryan Stafford, who's been heavily involved in many of the experiments that I've talked about this morning. So I'll finish there. And hand over to our second speaker, who is Jo.
Thank you, Paul. It's time to stand up again, if you don't mind. This time we're going to move from that mountain pose with our feet together to basically standing with your arms together and on one leg into a tree pose. So just moving gently. Seeing if you can take your foot just either below or above your knee, and let's do a little bit of pelvic floor activation as we breathe gently in and out. And you may sit down. Well done, everybody. So being a female, I will never truly ever understand what it is like to experience the men's health patients that I see on a daily basis have to endure. Given the minimal development of men's health physiotherapy to this day, most of my own knowledge has come from the more than 3,000 radical prostatectomy patients I've worked with over the last 12 years. This is who I refer to as the man on the street. And it is the man on the street and his quality of life that is of utmost importance to me. So looking at prostate cancer, the global statistics of its incidence are daunting. It is the most common cancer diagnosed in men globally, with 1.1 million new cases per year and over 300,000 deaths per year. There is a 1 in 7 lifetime risk for every man and a 1 in 4 lifetime risk for an African man. There is a 1 in 2 risk if there is any positive family history on the male side, and a 1 in 4 risk if there is any breast, ovarian or uterine cancer on the female side, and this is much associated with the BRCA2 gene. This, coupled with rising age, cardiovascular disease, diabetes, obesity, lack of exercise, and alcohol consumption are all great contributors. For the individual man who gets a diagnosis of prostate cancer, the impact can be overwhelming. They are often in shock, feeling angry. Often they're disbelieving of their situation as they often feel quite well. They are confused, they have fear and loneliness, and they're very concerned about the physical changes that may happen to them. There may be impact on their relationship and also all that represents their own masculinity in terms of work, sport, fitness, and they are often very distressed. But the biggest emotion I've noticed is one of shame. What men don't want to wear are continence pads, these nappies, and they're horrified that they may end up as a smelly old man wearing these. No matter their age, and my youngest patient is 37, it can be extremely overwhelming. So what actually does prostate cancer look like? Well, if we have a look at the pictures here, if you're looking at localised prostate cancer, you'll see we have T1 and T2 disease. There's a small blemish there in the first picture, which shows some abnormal cell development. Looking at T2, the second box, we'll see a little bit more abnormality. This is referred to as localised prostate cancer and is usually very easily treated by surgery or radical prostatectomy. On the other hand, if the cancer is more aggressive, it will start to leak or emerge outside of the capsule of the prostate, leading to often other organs, including the lungs, spine, lymph nodes, and surrounding tissues. At this stage, advanced cancer is very difficult to treat. Quite often there'll need to be radiation, hormone therapy, chemotherapies. If a man is diagnosed with localised prostate cancer, he has a 97% chance of living 5 years. If he is diagnosed with advanced cancer, this reduces to just 26%. So looking at what happens, as Paul explained, the pelvic floor muscle now has to take on a new job without the prostate, and the language I use for men is to say, your bladder and continence is basically being controlled automatically, but post-operatively, it becomes a manual system. And what we need to really do is focus on the pelvic floor, and in particular, look at the combination of function, including fast twitch, which makes up 30% of the muscle fibres, for the rapid actions to prevent leakage during actions such as coughing, sneezing, sit-to-stand activities, and sexually, and orgasm, and something called climacturia, which is leakage of urine during sexual orgasm, can be a most disnerving side effect. The opposite of that is the slow twitch muscle fibres, which make up 70% of the pelvic floor, which are involved in endurance and holding activities, including bladder and bowel continence and sexual function. After a radical prostatectomy, 99% of men will experience urinary incontinence or post-prostatectomy incontinence and erectile dysfunction. Pelvic floor muscle fatigue is perhaps the biggest component that I work with in my clinic on a daily basis. However, in my own clinic, if we do work pre-operatively and post-operatively, we're getting up to a 98% recovery of our continence function. As Paul said, there is actually evidence already abounding for pre-operative pelvic floor training. The most significant study is perhaps Centomero's 2010 study, which showed that a combination of pre- and post-operative pelvic floor muscle training was much better than post-operative only, with much quicker return to continence and a much shorter duration of incontinence. Clinically, I've seen that if we have a 4 to 6 week preoperative pelvic floor muscle training protocol, then our patients basically have about a 50% reduction of duration and severity. And typically, if my random sort of idea or guesstimation is that if we have 6 weeks of preoperative training, it tends to take just 6 to 8 weeks of postoperative, with an umbrella time of 3 months in total. Evidence for postoperative pelvic floor muscle training, as Paul also mentioned, is not completely desirable. The Cochrane review of 2015 that looked at the conservative management for post-prostatectomy incontinence investigated 45 trials and 4,717 patients. The conclusion from this was that there was no clear evidence that any pelvic floor muscle training is helpful in post-prostatectomy. Most disappointing. Also, the MAP study of 2012 between Gleisner and Dorey was also inconclusive. This, in my own opinion, is possibly to do with a low-intensity regime that was set up, which was just a combined total of 18 pelvic floor contractions per day in 3 different positions. So, a few years ago, when a patient of mine walked into my rooms with a screwed-up piece of paper, I was most impressed because before me was a situation where one physiotherapist from Queensland, Peter Dornan, had actually been through a radical prostatectomy himself. He had been suffering from post-prostatectomy incontinence for 7 years, and he had tried very much the women's health mode of approach to fixing his continence issues. Feeling quite depressed, he decided to do his own more intensive and aggressive program. He then went and climbed Mount Kilimanjaro, dry as a 6-year-old man. He then came home and published his book, Conquering Incontinence. More than 2,500 of my patients have accessed this PDF of his book, and I'm happy to say a lot of my patients, plus Peter himself, 22 years after his surgery, remains a continent mountaineer, still climbing mountains. But this is only half the story. The biggest shock of all came to me when I attended the 2014 Prostate Cancer Congress in Melbourne. Here were the results of post-radical prostatectomy erectile dysfunction. If a man was under 60 years of age, at 1 year post-radical prostatectomy, he had a 23% chance of regaining his sexual function. If, however, he was over 60, he had just a 4% chance of regaining his sexual function. Quite shocking statistics. There is a glimmer of hope, however, because in 1985, a surgeon by the name of Professor Patrick Walsh worked out that there were certain nerves, the cavernosal nerves, that could be protected, and he worked out a way to minimise bleeding. Then he is so famous that they are now currently called the nerves of Walsh after him, and it went on to lead to great changes and hope for many men. However, the research presents a much different picture. In fact, erectile dysfunction following radical prostatectomy is the most distressing side effect rated by men. 60% of men also repeat decrease in orgasm intensity and delayed orgasm. 10% will report pain with orgasm, and 1/4 penile sensory changes. Approximately half present a loss of penile length of more than 1 centimetre, with up to 4 centimetres potentially. 2/3 report worse sexual function and increased bother than that which they expected preoperatively. 70% will have an increased risk of depression and a 40% increased likelihood of suicide. 16 to 19% of men post-radical prostatectomy will also experience Peyronie's disease, which is just 3% and possibly a little more in the normal population. Approximately 2 years, the whole focus of my PhD research basically unravelled before me when a 46-year-old male patient knocked on my door. He was 13 months post-radical robotic prostatectomy. He had neither post-prostatectomy incontinence or erectile dysfunction, because both of those had resolved. But he was extremely distressed and wanted to show me this photo, as you can see in the top right-hand corner. His penis had suddenly changed direction when it was erect, and he was no longer able to have any sexual penetration with his 41-year-old wife, and he was devastated. He couldn't believe he'd had cancer, incontinence, erectile dysfunction, all resolved, to only be left with this. So I thought that I could do anything to help him, knowing that surgery would probably be the best option, but also understanding that this would further shorten the penis and create more scar tissue. So I looked into a little bit of research and discovered that in 1983 there had been one research paper looking at 26 patients where a doctor had used a combination of everyday therapeutic ultrasound in 26 men, of which 19 had approved. But then there was no further treatment. So I decided to give it a go, thinking, well, ultrasound helps scar tissue in most cases. And this is basically what's happening. We know that the radical prostatectomy leaves less blood flow. Approximately 4 to 6 erections every night are lost, leading to a 1,500 potential housekeeping loss erections per year. But we can prevent this, and physiotherapists can have a major role in something called penile rehabilitation, which is the use of any drug or device at the time or following radical prostatectomy to help facilitate the restoration of function. And this is a vacuum pump that most of my patients will be given between 3 and 6 weeks post-operatively. If they actually use this approximately 5 times a week, they'll end up having minimal penile shrinkage. So the pelvic floor has a major role to play with both functions. Fortunately, we also have the evidence. Professor Gay's story in 2005 was able to show that pelvic floor exercises done 3 times per day for 3 months improved erectile function in normal men by 75%. This gives me great hope, and so I've been working on how to develop some pelvic floor training exercises and a whole regime. But first I want to try and make the assessment easier for the man on the street. What I've basically designed are 2 pelvic floor non-invasive real-time ultrasound tests. The first being a rapid response test, where basically I want to see how quickly the fast twitch fibres are reacting by doing 10 pelvic floor maximal contractions as quickly as possible. Just looking here at the first screen, we'll see the bladder base, marked in yellow, gently starting to rise. It's at this point that I start my timing with a simple stopwatch on my phone, and I record how long it takes for the man to perform 10. Contrasting to this is a transperineal view, which I've most recently been looking at. In the first example, the patient takes 18 seconds and he is incontinent. In the second situation, the patient takes just 8 seconds, with a 7 to 10 second time frame being ideal. To deal with pelvic floor muscle fatigue, which has not previously been investigated in men, my sustained endurance test looked at the 70% pelvic floor muscle fibre situation. And this was a test where we simply asked the men to perform 1 maximal pelvic floor contraction whilst breathing normally and holding for as long as possible. What tends to happen is a male will, as we just saw on the left, start to lift the bladder base and then drop it down when he fatigues, or he may start to activate his abdominals to assist a little more. In both these situations, looking at the transperineal view, we can see that as the man starts to initiate all those muscles of continence control that Paul mentioned, there is quite a nice contraction, but what tends to happen over time, particularly in upright positions in supine, we get more fatigue. So pretty much no man that I see is incontinent either lying or sitting still, but once he gets upright, that's when the trouble begins. Okay. Basically what I just wanted to present to you was the future of where my work clinically sits right now. I'm currently recruiting men for exercise program looking at intense versus usual care study. And I'm also looking at recruiting men with Peyronie's disease, not just after radical prostatectomy. I'm hoping that my real-time ultrasound tests can be translated to erectile dysfunction, urinary incontinence and chronic pelvic pain in men, women and children, as they are non-invasive, and also that exercise programs such as the one I run in Western Australia for men who have prostate cancer, no matter the stage, age, can be involved in a community program to help them with their recovery. I'd particularly like to thank the South African Physiotherapy Society, and in particular Ina Dina, for bringing such joy to physiotherapists last week by having both the men and women working together in South Africa's first ever combined men's health physiotherapy course. Thank you very much, and I'll now pass you over to our next speaker, Dr. Ruth Jones.
Hello. Okay, I want to basically talk predominantly about pain. So the prevalence of chronic pelvic pain syndromes, 8% is estimated in the US. Most common neurological condition in younger men, less than 50 years old, and 66% of patients have symptoms 1 year post-diagnosis. More outpatient visits for prostatitis and prostate cancer, and the overall prevalence rates are likely to be underdiagnosed, in part due to the lack of agreed upon definitions and subsequent difficulties in categorizing chronic pelvic pain. So what type of symptoms are common in chronic pelvic pain? Urinary pain or urinary frequency. Rectal pain, post-bowel movement, constipation. Sometimes they'll say, I feel like I've got something inside, like a golf ball in my rectum. Perineal symptoms, ejaculatory pain, weaker erection, premature ejaculation, pain in the penis, or hypersensitivity to touch, penile retraction, discoloration, vascular changes. So I'm just going to give an illustration of what classically happens in my clinic. So I still work clinically. I had a 35-year-old SAS army captain. He was out of action for 5 years because he was unable to run without disabling left groin pain. He was diagnosed with a labral hip tear and an inguinal hernia, and he was treated surgically for those things with no effect. His NIH chronic prostatitis symptom index form revealed signs of urinary dysfunction, which he attributed to getting old. He's 35. Pelvic floor muscle palpation reproduced his hip pain. His hip range of movement was only 90 degrees. I had 4 treatments of trigger point release and movement system re-education, including the lumbar spine, pelvis, hip. His neural was clear over 3 months. All his urinary and pain symptoms were gone, and he regained his full range of hip motion. He was signed back operationally fit by the army. So the questionnaires, so if you can't reproduce their hip or abdominal pain, this is a really, really good way of figuring out whether there's a pelvic floor component to the problem. So the NIH chronic prostatitis symptom index form for men, and this is a validated form, and I get patients to fill this in pre-treatment, mid-treatment and end-treatment, and 99 times out of 100 the urinary frequency changes quicker than the pain stuff does. So once you start to see that, you know they're on the way. But that's a really, really good one. Now the thing is, it doesn't talk about erection dysfunction. So this is why if I get them to fill this in and it's positive, I'll then get them to fill in the next one, the pelvic pain Stanford one, because that actually talks about erection, which when you're female, sometimes guys talking about that to you can be really difficult. So by them circling something on the questionnaire is much easier for them to actually do. And then there's, again, you can go further on that and you can do the validated erectile function domain. That's another one that's very, very, very specific. So the recent research, pelvic floor muscle dysfunction measured by ultrasound is present in men suffering from chronic pelvic pain syndrome, correlated with pain, sexual dysfunction, and anxiety. The erectile angle at rest was much more acute in chronic pelvic pain patients than controls. And basically, the erectile angle is made basically by the pelvic floor muscles being tight. Okay, and classically, I've seen that on ultrasound pre-treatment and post-treatment. I'll talk a bit more about that in a minute. Then there was less upward movement. So can you imagine if your pelvic floor is like this already, then when you actually get them to contract, it can't go very far. Right? It's not necessarily because it's weak. It may be because it's overactive, which is classic. And the reduced contractile endurance because they're holding there already. So do they need to see a specialist? A urological review is necessary in some patients with urinary sexual symptoms and pelvic pain due to rule out prostate cancer, benign prostate hyperplasia, and urethral strictures. Most referrals in the UK are secondary post multiple consultant appointments. So they've gone to see lots and lots and lots of consultants, and then they come to you. So when you're assessing somebody, you need to look at the lumbar spine and neuromobility. Because if you have back pain, your pelvic floor works differently and doesn't necessarily go back to normal once the back pain's gone away. You need to look at the hip, looking at their breathing patterns. Everybody just here, just put your hand above your belly button, flat. Breathe in. What happens? Stomach comes out. So many times with patients with pelvic pain, it's exactly the opposite. As they breathe in, their stomach pulls in. So my homework, 99 times out of 100, is they have to go home with the idea, is my belly floppy? Am I breathing? Because if they're holding onto their stomach, they're holding onto their pelvic floor. Again, abdominal and pelvic floor palpation, looking at the sacroiliac joint, looking at the reliable pain provocation test, because you can do those pre-treatment and then do them afterwards, and they can change just like that. And the pubic symphysis palpation as well. And European Association of Urology published guidelines suggesting that trigger points should be considered in diagnosis of chronic pelvic pain. I just wanted to give you the idea. So the puberectalis is the most important for male pelvic pain. It refers to the tip or the shaft of the penis. I've called it Dr. Ruth's sign of the penis anyway. Anyway, there's a gapping sensation at the symphysis pubis, and it can refer pressure or fullness of the prostate. The obturator internus is the most commonly one to refer to the groin, the hip, and abdominally, and that sensation of there's a golf ball in the rectum. And the coccyx iliococcygeus, these refer to the coccyx, gluteus maximus, hamstrings, pre-bowel movement pain, full bowel sensation and discomfort, perineum, the anal sphincter, and prostate fullness pain. I always teach my patients how to do their own self-release if they're up for that. And using this, it means that the more that they do, the less they have to see me, and the quicker they get better. But so teaching your patients how to do their own release is really, really, really important. And again, 90% of patients with chronic pelvic pain had abdominal trigger points, and it should be considered a differential diagnosis. Okay, but classically, the rectus abdominis is overactive, and it can, again, reproduce all of those symptoms. So there's been one study, 48 patients with urological chronic pelvic pain, 2 methods, manual therapy, myofascial physical therapy with trigger point therapy, and global therapeutic massage. The global assessment was 57% of the myofascial physical therapy group, significantly higher than the rate of 21% in the global therapeutic massage, okay, suggesting a beneficial effect. But I just want to show you something. Okay, there are the results. In the females, the global therapeutic massage, there was no responders. Right? No responders. And guess what? Men, they responded quite well to the global therapeutic massage. And when they did the study, they just took it further just with the females. Okay, so just critically evaluate things that you read. So take-home message. If you've cleared all other sources of groin pelvic pain, consider the pelvic floor, especially if there's symptoms of urinary and sexual dysfunction. It's one potential component of the mystery of unexplained pelvic pain. And as I said, I'll take a multi-whole component part to this. It's a little bit of this, a little bit of that. Pathology is a component part of the problem. But we know that though that guy had lots of pathology, and they removed the pathology, but it wasn't contributing to his pain. So this is what we have to always consider. And then model management. We always talk about the joints, the discs, the muscles, the fascia, the brains, and now the pelvic floor. I want you always to be level, sceptical heads. Thank you very much.
So we'll hand the floor to Gerard.
Good morning. Just to get an idea of who's in the auditorium, could we just have a show of hands as to who currently treats patients with male pelvic floor dysfunction? Thank you. And can we maybe get an idea of people who would like to maybe get involved in this area of physiotherapy but currently don't? Maybe just show. Okay, so we've got a real mix of people. And thank you all for turning up at the symposium. It means a lot to all of us. I think firstly what I'm going to discuss is where are all the men's health physiotherapists? Because I think it's common, whether it's in the UK where I'm from, or kind of the Middle East where Khalid is from, or the States or Australia, that it can be quite difficult and challenging for patients to find someone who is able to treat them. And we sort of looked at this in Coventry University where I work, and did some work on what are some of the barriers to getting involved in men's health physiotherapy. It can be quite difficult to locate a peer group. You know, even if you work in a big hospital, it may be that you'll be the only physiotherapist in this area. So you might not have a local group of physios to kind of get support from. A lot of people in men's health physiotherapy work alone or work on their own. It's still quite a taboo subject. I think Joe has alluded to that. Men don't really like talking about penile pain, urinary incontinence, rectal pain. It's a real lack of training. It can be difficult to find a men's health physiotherapy course. Once you've done the course, if you're able to get in it, which can be challenging as well, because it's a very different type of work that, say, maybe female musculoskeletal or sports physios who haven't done women's health, it's quite difficult for them. It's quite difficult for the male physios if we haven't done that work. So it's quite difficult to find a mentor who will support you in that work. And there's also a lack of funding for men's health physiotherapy services. There are big barriers to attending men's health courses, and this is changing though. But I thought about this, that on the stage here we've got Khalid and myself and Paul. So in some countries it would be difficult for us to be able to attend a course because we haven't done women's health physiotherapy. And also Joe has got, seen thousands of prostate patients, but hasn't done any women's health physiotherapy or too much. So it might be difficult for her to go on a course. And also, similar to women's health physiotherapy, this isn't covered on most undergraduate courses. And I can speak from experience in the UK and from speaking to some of our very eminent American women's health physiotherapists, they kind of said the same. It's not really covered very much as an undergraduate. So it's this classic, it's how do you get experience? Barriers to developing a service. There's a real lack of public awareness of what we do. I think that's physiotherapy in general. There's a lack of professional awareness. A lot of the consultants, the urologists, the colorectal specialists, sexual medicine, our own physiotherapy colleagues have no idea really that we treat pelvic pain, that men get urinary incontinence, that men get erectile dysfunction, that men can be treated for premature ejaculation. And there are lots of taboos. And this was echoed really nicely in the Guardian newspaper several weeks ago, where they kind of questioned about 100 men on their thoughts about their penis. And generally, the main thing was lots of anxiety. And these were people without any symptoms or problems. These men are out there, prostate cancer, 1 in 7 men, 1 in 3, 1 in 4 in certain groups. As Ruth has spoken, pelvic pain is very common. Male pelvic pain is a common underreported condition with devastating effects on quality of life. Colorectal cancer is the 3rd most common cancer internationally. And also, those of you who work in musculoskeletal and sport, a lot of those very resistant pubic symphysis, hip, groin problems may have an underlying pelvic floor component. The patients are out there, and there's a real onus on us to do our best to reach them. Mentoring is critical for this type of work, and it is really important that, you know, if you have had some training in men's health, it's better to then find someone to mentor you in that work. In my experience, I've had a lot of support from my local women's health physio community in Birmingham, and but it may be that you don't have that around you. So it may be that it's a local consultant, maybe a pelvic pain consultant. It might be a urology nurse specialist, and they don't have to be local to you. I know another person who has supported a lot of people globally is Peter Dornan, myself included. And on the course last week, one of the male physios said, you know, they were getting lots of patients, didn't know what to do with them. They messaged Peter, and he was very supportive of them. And as Dr. Emma Stokes has frequently said, you know, if something can be done by one person, then it's not a big enough project to do. So who are the key players, or who are the gatekeepers who might help you reach these groups of men? I know in some countries there are big online forums for patients with male pelvic pain, patients post-prostate cancer. The cancer charities, especially with us, we've got Prostate UK. It's a very powerful organisation, colorectal cancer organisations. And in your countries, there will be similar type groups. And those charities also probably organise local support groups. And when you contact them, you're pushing at an open door. They will probably say, we would love you to come along and speak to us. In some countries, the nurse specialists are very important, especially the urology nurse specialists, because they tend to see a lot of these men post-radical prostatectomy. And also some of the commercial companies. And I know physios sometimes are a bit reluctant to get involved with anything that's got a commercial spin. However, we have a vacuum pump here. So that the companies that give these out to the men post-surgery, they have huge databases of men who have erectile dysfunction, urinary incontinence, and if you get involved with some of those companies, they will tend to disseminate your information. It's good to kind of go and speak to the consultants. I think physios were very good at communication. You know, most people in the room here will have probably met loads of new friends these last couple of days. But sometimes we're not as good as going in to speak to the urologists, the colorectal surgeons, the nurses. And I think we need to get out and have those conversations. And also to speak to your colleagues. You know, your physio colleagues will be picking up men who have these problems, but they may not know what we all do. And some of the people that I've interacted with is the people in elite sports, that's more the athletic pelvic pain, the urology nurses, and this is a support group in the UK. And all of these people, when I contacted them, they said, it would be great for you to come along and chat to us. How important is social media? It has a role, but it's one part of the jigsaw. It's quite important to connect with other people in men's health, and that's kind of how Joe and I met initially. Gives you access to some of the media platforms like kind of local radio, newspapers, gives you access to the professional groups. So that's how I would have got involved with Prostate UK, with the urology nurses. And it also helps you promote what you do. The public have no idea what we do. Most of our colleagues have no idea what we do. And it's a very good professional resource. A lot of people will probably be following WCPT on Twitter. You know, we're all very fortunate to be here, but most physios aren't here. And it's also good to be creative on social media, to put stuff up that draws people to what you do. However, it can be quite time-consuming, can be quite draining on your time. So it's good to ask yourself, well, what has Twitter enabled me to achieve in the last few months? To really keep an eye on what's happening on it. Facebook is very powerful for us because we have the Men's Health Physiotherapy Facebook group. In it, there's about 1,000 physios with an interest in men's health. So that's a good professional resource. And also, there's a lot of kind of patient support groups on Facebook for the prostate cancer, for pelvic pain. And also a lot of people are on Facebook now. So it may be that, you know, that man with prostate cancer isn't on it, but his daughter might be on it, his partner might be on it, his granddaughter, grandson, and they might say, well, you know, so-and-so might be able to see you because you've had prostate surgery. I think sometimes we're not really comfortable about promoting what we do, but if you have a men's health physiotherapy service and people can't find you, that means that they don't know you're there. And I would spin this in a way, we have a responsibility to reach these patients. These men are in a bad place, and it's good to kind of use Google for that. So what can you do? What we'd like you to do is maybe to tweet us one thing in your role as to what you could do to promote men's health. Whether you're in work for the professional body, whether you're a clinician, whether you work for a special interest group. Change is needed, but it is happening. So last week, thanks to EINER and the South African Women's Health Association, we had a men's health course and we had 8 male physios on it. So the men showed up. And that went really well. You know, some of the organisers of that said we had deliberated about letting men attend, and we had lots of men and we all practiced on each other, and it worked really well. And I think the people here will say that course, it flowed very well. There were no issues having males, females. It was quite nice to see. So what can we do? I think we need to challenge the norm a little bit. We would advocate for name change, but this is happening. It's happened in New Zealand. It's happened in Australia. It's currently in discussion in the APTA. It's currently in discussion in the WCPT special interest group under the stewardship of Jill Brooke. It would be good for organisations to review criteria necessary to attend courses. 2 things: let the men attend, and also make it easier for the non-women's health physios to attend. It would be good for conferences to follow the WCPT example. So if it's an oncology conference, sports injuries, women's health, to create some men's health content. Try to embed a little bit of men's health in the undergraduate programs. Join Joe's group and follow Nuts to Guts. And the take-home messages are, we know there are multiple barriers to men's health physiotherapy, but the patients are out there, and these men and their families are in desperate need of help, and we can give them that help. Change is happening, but we as physiotherapists need to be more visible and throw off these taboos. And if you are part of that process of change, the men and their families will thank you. And I would like to thank Coventry University, the South African Society of Physiotherapy, particularly Ina Dina and the Women's Health Association for inviting Joe and I to teach last week, WCPT, and all the patients that I've learned a lot from. And I would also like to thank Joe and Ruth for their support and mentorship of me. Thank you very much. And I will pass you over to Khalid.
Hi, I'm here on behalf of Sumoto, who's a colleague from Nigeria who couldn't be here because he couldn't grant a visa, which is highlight one of the important problems that we have as an African physiotherapist, that we don't have accessibility. I have been practicing mental health for 7 years. I've been practicing physio for 25 years. 7 of them is as a men's health physiotherapist. And I practice actually in 3 continents. I practice in North America and United States, and I practice in Egypt, and I practice in Asia, in Emirates. The first thing you'll notice in Sumoto presentation, the next few slides are going to be kind of plain slides, which exactly highlights the situation of mental health in most of African nations. It does not exist. And I'm talking about mental health physiotherapy and rehabilitation. The average lifespan for men in Nigeria is 53 years old, which is much lower than the rest of the nations. And types of illness over there: malaria, HIV, influenza, cancer, diabetes, stroke, GIT diseases, liver diseases, coronary heart disease. The education rate for literacy among males is 67%. And the work, 2006-2007 data, skilled workers only 37%. This is a typical setup in Nigeria in a rural physiotherapy clinic, which, as you see, is a big difference between what I practice in North America, in Egypt, in Dubai, and even in Africa. It's again the same. His experience in mental health. Mental health in Nigeria is practically does not exist. Initiative programs designed to address the numbers of health problems in Nigeria. Nigeria constitutes 2% of the world's population, and it's the largest population in Africa. Nigeria, in fact, mortality rate is 86% per 1,000 live birth, and maternal mortality is 840 per 100,000 live birth. Maternal mortality in Nigeria is 36,600. Nigeria has failed to address the women's health, which is believed to be 30 years ahead of mental health. This again highlights that mental health rehabilitation does not exist. Prostate cancer incidence in Nigeria. In 1997, hospital-based in Lagos State studies reported that incidence of 127 per 100,000. In 2013, study in Lagos State reported an incidence of 1,046 per 100,000. It has 80% mortality rate, increasing in this by almost 100% within a period of 4 years. 26 Nigerian men die every day from prostate cancer. And this is the National Agency of Research on Cancer, and this is the numbers. A typical prostate cancer journey in Nigeria, because there's lack of screening and lack of annual checkups. Patients notice any prostate cancer symptoms, example, spinal pain, metastatic fracture, rectal bleeding. Usually he goes to assessment by a GP and referred to a urologist. It's a very long trip. Evaluation assessment by a urologist. If confirmed to be a benign prostate hyperplasia, a simple open prostatectomy is done. If it's a confirmed case of cancer of prostate or chemotherapy is done to shrink the prostate. Rectomy is a surgical removal of the testes to shut down the synthesis of testosterone, thus removing testosterone stimulation of prostate cancer growth and alleviating for a while the symptoms of progression of the disease. And I believe this procedure has been completely vanished from the Western world now, right? They're still doing it there. A top urologist that I interviewed said that he had only witnessed 3 radical prostatectomies in 10 years. There is no such thing as a local prostate cancer treatment as it is not tested. Men are usually at advanced stage when they are diagnosed. This takes 30% versus advanced countries. Does physiotherapy have an established rule in prostate cancer? Physiotherapy has no rule in not just prostate cancer, but cancer as a whole in Nigeria. Lack of qualified physiotherapists to take up the roles in prostate cancer management. Lack of interdisciplinary relation. What needs to be improved in Nigeria in mental health? And this can be applied for most of the African countries. Awareness. Awareness this is the biggest hurdle for us to practice physiotherapy in mental health I think all over. Awareness first has to be among our colleagues. I was walking around in the last few days in the conference here, and I was asking most of physiotherapists that I meet, do you know what's mental health? Do you know what we do? I was really astonished that they have no idea what we do. And awareness has to be first among our colleagues, second among the healthcare providers, and third in the society. Free checkups and screening. Bodies should synergize with the government through the media. Physiotherapy role in chronic health care such as cancer need for mentorship. Public health campaigns are for men in Nigeria. Currently, there is no public health campaigns for men in Nigeria, despite the fact that prostate cancer is the #1 cancer killer in Nigeria among men. Prostate cancer killed a former deputy senator president in Nigeria in May 2014. I don't know how to pronounce his name. Were as well the former Secretary General of the Organization of the Petroleum Exporting Countries, the President General of the Thupu Progress Union. So it killed a lot of very famous people and is still not addressed. It is also alleged that our current president is suffering from prostate cancer and is still not addressed. What would I like to see happen with the physiotherapy program? First, positive drift from the status quo to what is in the vogue or obtainable in advanced countries. Trained manpower, scholarship, equipments, resources, seminars, textbook, radical changes in the curriculum in the physiotherapy schools, as the most physiotherapy lectures has refused to upgrade. Competent lectures. This is a very good one. What's coming to the WCPT means to Somoto and what he's taking back to Nigeria. Exposure. Create an impact in the society. I'd like to just tell you a story about what's my first experience with mental health. That started 7 years ago when I walked in my first course, and I entered among 39 female physiotherapists, and all of them looked at me and said, "Why are you here? What you're doing here?" I believe that the computer lab is next door. And this is exactly highlights the situation till last year. And this year I was really surprised to find 8 physiotherapists attending the South African men's course with Joe here. And I think this is a big move from 7 years to now. Thank you. I have a message from Samto.
He's just sent a message.
Yeah. And my sincere gratitude goes out to everyone in the WCPT, my colleagues in the men's health presentation, and Joe. I feel disappointed and happy at the same time. I'm disappointed because I couldn't be there to meet you in person, but happy also because my team wasn't disqualified because of my situation. 4th of July this year was supposed to be my own Independence Day, a day of new beginning in our noble profession, physiotherapy, a day in which my career shifts to another dimension. I believe that destiny can never be denied, rather it will be delayed. Thank you to everybody, and to Joe, whom I can't thank enough for qualifying me where I wasn't qualified, and her kind gesture towards me. Joe is an angel. Thank you, and God bless.
Well, thank you, Khalid, for standing in for Somto. So we now have some time for questions and then some time for a summary at the end. Is there anyone in the audience who'd like to ask a question? We don't have microphones, but if you could speak loudly. Oh, there is a microphone. If you'd like to make yourself known to the microphone holder and state who you are, and then the question would be great. Well, there's a question down here. This is the physical activity part for the second half of the session.
Thank you. Thank you all for an excellent session. The Karina Avni, Cape Town, South Africa. Paul, those are lovely images looking at the male pelvic floor and the movement and the differing patterns. Have you used that with men who have pain, or are you still trying to describe normal?
So the majority of the clinical work that we've done using those methods have been with men with incontinence. So we've done the preliminary component of a large randomised controlled clinical trial, and the major part of that trial will be starting soon. So in terms of incontinence, I think we're well established in understanding how we might use the information. In terms of pelvic pain, I have a student who's working on pelvic pain at the moment, and we're starting to use those measures, but Ruth has certainly had some experience with using similar measures with her pain population. Did you want to talk to that at all? Just push the button. Yeah.
Okay. I've been using ultrasound pre and post-treatment, and what shocked me when I measured the anorectal angle and the acuteness of that, I did a spinal technique, a normal Bob Elvey technique or a manipulation technique, and the angle of the pelvic floor changed completely. The anorectal angle was much less acute and much further away from the pubic symphysis. So there is magical work to be done. You should blinking well do it. I'm trying to hint for somebody to do another PhD, please.
There's also work from Melanie Moran's group in Sherbrooke University in Canada, where she's been using ultrasound imaging for looking at signs of increased tone in men with pelvic pain. So I think there's lots of potential. Yeah. Another question?
Yep.
Okay.
Wendy Bow from Melbourne in Australia. So I just want to know if you've got any guidelines about the physical activity that we are suggesting post prostatectomy, or just to fight the inflammatory changes and reduce the likelihood of future cancers, and what's the evidence for that?
Thank you for that question, Wendy. There is actually an extensive amount of research. If you actually look up the name Professor Rob Newton and Daniel Galvao, there's some researchers in prostate cancer care, both advanced and localised disease, from Western Australia once again. Basically what they recommend is 150 minutes per week of general exercise, such as walking, or five sessions per week, 30 minutes each, plus 3 sessions per week of a combined cardio and resistance-based exercise program. What we really have been pleased to see that particularly patients who are in the advanced groups, things such as osteoporosis becoming a problem in metastatic disease. The Galvao and Newton team actually put guys through this, and they didn't have one negative impact from this exercise program that was designed. So the whole shift is actually changing in the fact that we now know that exercise is an integral part of treatment and rehabilitation. In my own exercise program in Western Australia, basically the opportunity to link in with other men going through that prostate cancer experience, no matter what the stage, has certainly proved pivotal in the psychological benefits. And the patients are actually teaming up with each other and going for coffees and just having an opportunity to share. But there is an extensive amount of research across the board that says things like PSA rises can be minimised by this same approach. So it's something that we as physiotherapists can definitely be involved in the education process.
So have they looked specifically at the HIIT, the high intensity training?
As far as I'm aware, not yet in the prostate cancer domain.
So Gerard's got 2 external questions through Twitter or Facebook.
Yeah, because the Facebook men's health group has been so supportive of a lot of people globally, we were quite keen to take some questions. One question from it and one from Twitter. So we have a question from the WCPT Connect Facebook group, and this is from Elaine Miller, who's an advocate for particularly women's health physiotherapy in the UK, and she has asked, what are people's most successful strategies for getting men to engage with healthcare in general and physiotherapy? So I'm happy to answer that initially and then bounce it to maybe Khalid. So I think what has been really shifting in general is the big campaigns like Movember, and in the UK we have Men United. And I think men want very good quality information that's very easy to access. And what I think's been useful, I think personally, is to produce some patient-focused blogs that are short and sweet, easy to find on Google, talking about, you know, maybe the patient story, what it's like to have urinary incontinence, what it's like to be a young man with pelvic pain, what it's like to be a young man with, or older man with maybe ejaculatory pain. So I think the blogs are good. So it's kind of pumping out this patient-focused information. And also what Ruth and I did quite recently, which has got really good feedback from a lot of patient groups, is the podcast. So we asked some of the patients in the forums, what do you want to know about male pelvic pain? So they sent us in some questions. Ruth and I kind of did a short 30-minute discussion and just recorded that, put it up on the web, and that type of easy access information seems to really help engage the men.
I have a message for. Sorry. I have a message for all men's physiotherapists who would like to tackle this issue. First message is men's mental health physiotherapy is not the same as women's health physiotherapy. It's totally different. Number two, mental health physiotherapy is not only internal work. It is farther beyond that. We have a big role in erectile dysfunction. We have a role in premature ejaculation. We have a role in testosterone dysfunctions. We have a big role just educating men about sexuality and the physical act of intercourse. So we have a further role. It's not only you take in your hands and you do internal work. It's farther beyond that.
And then we have one last question from online, and this is from a UK physiotherapist who does men's health, Adrian, and he has said, kind of, why has physiotherapy not embraced men's health, and should it be separate from women's health? Personally, I think it should stay with women's health, because we need that expertise and training and mentorship and education that the women's health have that expertise with. But I think name change is important to make it visible that it's women's and men's health and PEDS, rather than being hidden away under the umbrella of women's health. But I'd appreciate the opinions of the others.
Myself, I'm basically reiterating exactly as Jared has mentioned. I think we have a lot to learn from each other, and I'd much prefer it to be an umbrella name, including men and women's health and children. So I think we're all very united in trying to have that happen, and it's great to see New Zealand pioneering that, as well as Australia follow second, with many international organisations also looking at hopefully following their lead.
Great. Now, there was another question from down here. Yep.
Hi, Melissa Davidson from New Zealand. I was part of the name change thing. I'm now secretary for the IOPTWH as well. So I've got dual heads on. Just question, most of us do not have access to ultrasound to be able to see the recruitment or the skill level required to figure out what they're doing. Is there something we can detect via palpation that triggers various, be able to help us clinically reason our way through what is going to help these patients the best if they've got different strategies, pulling the turtle head in versus walking into Lake Wakatipu and having your testicles pull up, for example?
Sure. I'll start with that, and I'm certainly sure that people in the rest of the group can answer as well. I think there's many things we can do with that ultrasound. I think the ultrasound has been really helpful for us to understand what aspects might be important and the variation in presentations that men have. What our data shows is that the sphincter is, in the majority of men, the major contributor to the problem. So focusing on that as part of our intervention is probably universal, but it's not going to be possible in all men because there will be some trauma. Evaluating the impact that adding a contraction onto a task like cough can tell you whether activating those muscles can have an impact. Rectal examination can certainly tell you whether someone's contracting their pubic rectalis. Whether or not it can tell you more about the urethral mechanisms is not yet clear. So it can also tell you about overactivity, and certainly what Ruth was talking about in terms of if it's already contracting more is not going to be helpful. So there's definitely things that we can gain from that. From external palpation, we can certainly evaluate whether a man is contracting the bubocavernosus, and that is contracting as part of the mechanism. So we certainly can use that as other information. And every man, every time he coughs, uses those muscles, so it is part of the system. Clearly, you'd want something a little bit earlier to be contracting as well, but it does give a possibility. And the other is, of course, looking at a person's abdominal contractions and breathing. And are they generating too much from above? Because if many men are, and on average our men push down rather than elevate. So I think there's a whole host of things that we can use for tailoring and refining interventions that don't require the ultrasound. But if we have ultrasound, and hopefully our profession can get access to cheaper ultrasound in the future, and it is getting much cheaper, I think it just gives men it's often a game changer that they can see the muscle and instantly they understand, oh, okay, there is something happening down there. I know what you're talking about. So I think it's got some big advantages. Yeah. Did anyone want to add anything to that?
I think the patient. I see a lot of male pelvic pain patients, and I have an ultrasound machine, but I don't tend to use it that much on them. It's used a lot for the prostate patients, kind of doing what Joe has recommended. But I think for male pelvic pain, it's useful, but it's not essential. And they're very, very expensive.
I'd just like to add there's some really simple tips. Craig Allingham has written a book called Prostate Recovery Map Book, and he very clearly states that it's all about the patient actually understanding what they need to do. And I know that what he basically says is it's the front muscles, not the back ones. It is more important to know how to lift the testicles than to stop a fart. And basically, having the language which a man can relate to gives patients the opportunity to be able to take a little message home. What he also describes is to perhaps get a man to be in standing position and to very gently place his fingers between his anus and his scrotum and to actually just let everything soften, and then to very gently try and draw up from that area, like shortening the penis or just lifting the base of the penis and drawing the testes up to try and feel a contraction. I also get my patients to basically go and stand in front of the mirror naked at home and to really emphasize to relaxing the abdominal region to start with. I also get them to internally rotate their feet so they can take a little bit of the glute max cueing out of it, and then to get them to actually practice those gentle drawing up actions without actually using all those other things. And quite often they're very pleased to see that their penis does retract slightly and that their testicles rise. And so it's a really simple couple of home self-tests that they can do. And certainly I sometimes work in the country and I've not always had my ultrasound machine, so a little bit of palpation is definitely helpful. Pauline Chiarelli actually has a DVD that the Prostate Cancer Foundation of Australia helped her put together, and it's still very relevant to where we're at today.
And one final question. Yeah.
Sorry, I may have three for Mrs. Ruth Jones. The first one is about, you said the range of the hip with chronic pelvic pain patients in men was 90 degrees. Was that mostly medial rotation or?
No, that was just that particular patient. But
was it lateral rotation or medial rotation that you?
It was flexion.
Oh, okay.
It was and I'm not being funny, but often the obturator internus is so overactive, and you release that, and the range of motion can just change like that.
Have you found that a decrease in medial rotation of the hip is often associated with chronic pelvic pain, like you would find a GERD in the shoulder?
I haven't looked at that specifically, so I wouldn't be able to answer that specifically, because I always check the range of motion, but sometimes it's because it's retroverted or antiverted hips anyway. But I haven't gone, oh, is it medial rotation, particularly limited? But if I'm just reviewing, yes, that's my gut feeling. Yeah.
Okay, and another thing is the hypertonic patients. Do you often find that it's associated? Do you have a lot of premature ejaculation that's associated with that?
Very much so.
Okay.
Very much so. And again, it's 99. Honestly, everybody gets so anxious, and I always say, look, a frightened animal. What happens? Tail goes between the legs. That's the action of the pelvic floor. We just don't have a tail showing that's what we're doing, and they really get that, and just getting them to let go. And doing that combination of meditation and stuff like that alongside the physical measures, it's really, really, really useful. Just got one last thing. They did this study. They took over 100 people who had not responded to any form of intervention, right, for pelvic pain, and they made half the group walk at for 30 to 40 minutes 3 times a week at 100 beats per minute. They did the other group, same length of time, but 70 to 80% of their maximum heart rate. These are people who'd failed every intervention. Both groups did significantly better, pain and function, but the people that walked at 70 to 80% of their maximum heart rate did even better. So I say it's a no-brainer to all of my patients to basically do that, to get them doing that physical activity, 30 to 40 minutes 3 times a week, 70 to 80% of the maximum heart rate.
Okay. And Khaled, did you have?
There's only one paper was published in actual physiotherapy and premature ejaculation and the role of physiotherapy in premature ejaculation. What they did, they did pelvic floor strengthening exercise, electric stimulation, and biofeedback, and they had 82% improvement in the time. I think it was less than 30 seconds, and they reached to a few minutes. What I added myself, neuromuscular re-education for the pelvic floor and how they differentiate between the contraction between the pelvic floor during the pelvic rocking action and the contraction of the pelvic muscle during the ejaculatory effect. And I found this actually teaching the patient the difference and how to differentiate between the contraction of both muscles and the pelvic floor muscles actually help to lengthen the period. I also added the vacuum pump exercises as a daily exercise for the penis, as decreases actually that stimulation and gives some kind of confidence for those men.
Okay, so thank you very much for the extra information. We now need to draw the discussion to an end, and it's great that there's been discussion. And what we've noticed, of course, over the last few days is that there is this increasing energy related to the consideration of men's health in our profession, because it is an integral part of what we can provide to our patients. It's clear from the session that there is an enormous diversity of presentations of men, a whole host of different conditions related to pelvic floor function and related to men's health in general that we need to consider that can fall under this umbrella of men's health. And we've heard lots of snippets of information about different conditions within this spectrum. We know that there are differences between men and women. We do need to consider that different interventions may be necessary for the male population, and we need to understand those differences. There's different anatomy, there's different mechanisms and pathologies for symptoms that may present in the same way, but there's also different conditions, there's different assessments and there's different treatments. So it is different, and we need to embrace that, and we need to encourage improved understanding of that. In terms of assessment, there's multiple features that each of the speakers has presented, ideas of patterns of activation and overactivity and trigger points, endurance, speed of contraction, different questionnaires that may be helpful. So there's a host of things that we do need to consider in terms of evaluating so that we can tailor interventions. It's clear that treatments need to be multidimensional. We've talked about muscle rehabilitation and motor control training, pain management, thinking, of course, about the biopsychosocial model and the interventions that can target psychological features in pain. We need to think about things like bladder training, voiding behaviours, diet, education, weight management, physical activity, penile rehabilitation, relationships management, all of which we can draw on from the diverse expertise that we have as physiotherapists, and particularly drawing on the expertise that comes from the continence and women's health experts within our profession. We need to think about instructions and cues, and we've heard a lot about different cues today, and I think we need to do some studies to work out what do we really do when we do different instructions. There's many instructions that have been used across the literature, and each of them does have the potential to achieve different things. So you've heard about the idea of lifting the testes, you've heard about the ideas of shortening or retracting the penis. The most common thing that people use in clinical trials for post-prostatectomy incontinence is tighten around the anus, and clearly we have some reservations about whether that's the best instruction. But we need to consider that maybe we can be tailoring our instructions to have some impact on contractions, and we've done one study, but there's a whole need for many other experiments. For example, that idea of shortening the penis does seem to bias the sphincter, so maybe we can be selective in what we do by using appropriate instructions. We need to think about research. Clearly, research is necessary to change practice and change attitudes and beliefs within our profession, within our associated disciplines, but also understanding of patients. So understanding mechanisms, validating our assessments, testing our interventions, and identifying if and how we should individualise the treatments that we do. There's a whole lot of research being done, not only by physios, but also other individuals that are providing insight into the problems that we address. For example, some work that's been done by Jason Kutch from the US is looking at brain changes in men with chronic pelvic pain and showing changes in the motor outputs from the brain in those men. So there's many things that we can draw on to help understand and refine our treatments. We need to have the flexibility to be creative because new methods are required to address the challenges that we face. We need to think outside the box, and we need to think about how we might tailor interventions to target the presentation that a man comes with. We need to think about diversely, and we've heard lots of discussion about the idea of breathing, the idea of abdominal changes, of the interrelationship between back and hip pain. So we need to think in a broad way about these problems. We obviously need to think about education. So what are the optimal methods that we can use to educate physiotherapists to apply these treatments through? And we've heard from Gerard some ideas about mentoring and support using a whole diverse range of different approaches. We clearly need to work as advocates. Advocates for our own physiotherapy colleagues who work in this area, supporting the growth of this specialty within our profession and identifying the best ways to govern that within our profession. And we also need to be advocates for our patients, and we certainly heard from Khalid the problems that are faced in many countries, particularly in Nigeria, as we heard from Somto's presentation. So there's many unmet needs. We need to educate the policymakers, we need to educate clinicians, we need to educate patients. So I'd like to finish there by thanking everyone in the room very much for coming along to the first symposium, Focus Symposium in Men's Health held at WCPT, and thank very much the panel of esteemed experts who've come along today to talk about their own view and their own piece of this puzzle of men's health. So I'll finish there. Thank you.